Hi, I'm Shaji Kumar. I'm a hematologist at Mayo Clinic in Rochester, Minnesota. The treatments for myeloma has continued to evolve, and outcomes for patients with multiple myeloma continues to improve with the new therapies, particularly immunotherapies. However, there are patients in whom extramedullary disease, which is the formation of the myeloma cells or the spread of the myeloma cells beyond the bone marrow, becomes very difficult to treat. And we see more and more of this extramedullary disease as patients go through multiple different treatments and the myeloma becomes resistant to the available treatments. Even with the immunotherapies like the CAR T cells and the bispecific antibodies, which have been really exciting and a major advance in the disease, we still see patients developing extramedullary disease and not responding for long periods of time with these therapies. So the redirect study phase 1 trial was designed to explore the combination of Teclistamab, which is a bispecific antibody targeting a protein called BCMA, and Talquetamab, which is another bispecific antibody that targets a protein called GPRC5D, both of which have been individually approved for treatment of relapsed myeloma, was combined to see if we can actually get a much better efficacy by combining these two different bispecific antibodies. Now, again, the bispecific antibodies work by bringing the immune cells, the T cells, close to the tumor cells and leading to the tumor cell death by the immune cells. What we have seen is when patients with relapsed and refractory myeloma is treated with either teclistamab or talquetamab by itself, we get about a year to year and a half of disease control. And when we use the combination, what was seen in the Redirect 1 study was that we get a much higher response rate. In the original study, almost 90 plus percentage of patients actually responded to the combination compared to maybe 60 to 70% for each of them used alone. What was more interesting from the Redirect 1 phase 1 study was that there were some patients, about a couple dozen patients, who had extramedullary disease. And these are, again, myeloma that is spread completely outside of the bone marrow, not connected to the bone marrow anymore, and growing independently. These patients, when they were enrolled on that phase 1 study, had a response that was higher than what we would have anticipated and also had more durable response. So it was decided to do a separate study just focusing on patients with extramedullary disease. And it's important to note that these kind of studies focusing just on the subgroup have not been done in a large scale before. So this phase 2 study only enrolled patients with extramedullary disease. So these are again lesions that are being identified on a PET-CT to be independent of the bone marrow, and they were all large enough to be measurable. And these patients were then treated with the combination of teclistamab and talquetamab. All the patients received 3-step-up dosing with gradually increasing doses, and then the full dose that was given every other week for both teclistamab and talquetamab. And after 4 cycles of treatment, if they had a deep response, say VGPR or better, or after 6 cycles, irrespective of the response, they could go to once a month treatment to make it much more easier. The primary goal of the study was to ascertain what proportion of patients actually responded to this combination. And what we found in the phase 2 study that enrolled 90 of these patients was that almost 80% of the patients, 4 in 5 of them, actually responded to the treatment. And these responses were confirmed by PET-CT scan showing that the extramedullary disease had in fact shrunk. And these are patients who did not have a lot of treatment options because they had a median of about 3 prior lines of treatment. 90% of them were triple class refractory. Nearly half of those patients were refractory to the 5 commonly used drugs among these 3 classes. And what we also saw in this study was that these responses were in fact durable. The median progression-free survival was about 15 months, and almost 60 to 70% of the patients were progression-free at 1 year from the start of therapy. And those 80% of the patients who responded, the median duration of response also was bit over a year, with almost 60 to 70% of those patients free of disease progression at 1 year from the start of therapy. And the overall survival for this cohort of 90 patients was much more than a year. Again, not what we would have expected had they not had other effective treatments. And in terms of side effects, obviously one is concerned that whether are we going to amplify the side effects when we combine these two drugs. We are all familiar with the side effects with the bispecific antibodies like cytokine release syndrome, neurological side effects, infections, low blood counts, and also some unique skin and taste related toxicity associated with the talquetamab. What we found was that the combination did not cause any more side effects than either of them used alone. We did see cytokine release syndrome or CRS in about 70% of the patients. Mostly were grade 1 or 2 and very easily managed. The neurological toxicity was seen in about 10-12% of patients, again, mostly grade 1 or 2 and easily managed. We saw infections in about 70% of the patients, 70 to 80%, and in about a third of the patients were grade 3 or grade 4, which is kind of more severe infections requiring maybe hospitalization or IV antibiotics and so forth. And again, most of these infections were related to pneumonia and similar infections, and they could all be managed. What was also important to note was that even though the patients, many of the patients went to once a month dosing after the 6 cycles, the responses held and they were durable. And in some patients, the responses continued to deepen. And many of these patients who were in a complete response were also minimal residual disease negative. So putting everything together, it's clear that combining the teclistamab and talquetamab provides a very effective treatment option for patients with extramedullary disease who have become refractory to other conventional treatments. And given that both these medications are currently approved and available in the clinic, we have the opportunity to use them in combination. In fact, the NCCN guidelines already include the combination of teclistamab and talquetamab in certain circumstances where patients have relapsed myeloma that is not responding to other therapies. And it seems like we are able to do that not only with increased efficacy, but also with added toxicity and toxicity that is manageable with the current supportive care approaches. And it's also important to note that this is one of the largest studies to be done in extramedullary disease and provides a good example of why we need to be studying these high-risk myeloma subpopulations in individual trials so that we can actually make a good assessment of what works best for these patients. They had plans of exploring a regulatory approval. I'm not entirely sure where we are at that, but irrespective of whether we use the data from this clinical trial for regulatory approval or not, there are other phase 3 trials that are also exploring similar combinations, and that also includes patients with relapsed refractory disease. And hence, this combination will become available for use in relapsed myeloma, I hope, in general, in which case then we can certainly prioritize its use in patients with extramedullary disease.